You're too slow.
The whole idea is, first of all, to introduce you to this format, because you learn the neurological exam as part of that whole long exam thing. And this is the format that you will encounter in hospital charts. This is the way the neurological examination is done in this country, if it's done as a standalone exam. The neurological exam, just like the general physical examination, is rarely done, completely. With time and with experience, you'll learn for a given patient what parts seem to be the most relevant to do, and you'll hone in on those. But just like you have to learn the general physical examination, you need to learn how to do all this, because this is a learned skill. Using the reflex hammer is a learned skill. It's not something you can just pick up and go do it, like I do it, okay? I probably tapped as many reflexes as Steph Curry has taken jump shots. Sad thing is, he's much better at jump shots than I am at reflexes. Okay, also better looking too, and a lot of other things. Anyway, what we're going to do today is I'm going to take one of you and go through this, and then the fun part, we got 5 exam rooms, and we're going to divide you into 5 teams of 2. And you're going to take turns playing the neurologist and the patient. When you are the patient, you'll have a little scenario that I'm going to give you, and you read that, and you don't let your doctor see it because it tells everything. And he will ask you the history of your present illness. You'll then give that, and then he will do a neurological exam on you. And I would like for you to try, because you've got about 30 minutes, because you're going to do this twice, so we're going to allow at least an hour for the clinical part of this. So you'll each have 30 minutes to play doctor and play patient. So try to do as much of this as you can, because practice makes you better. And basically what I want you to do is examine the patient, and when you're playing the patient, you have to fake the abnormalities, and your little scenario tells you which things to fake. And then if you're the doctor, you try to figure out where the problem is in the nervous system. I don't expect you to tell me, what exactly the problem is, but I am going to try to recreate as best we can what I used to do every day. A patient would come to me, he'd tell me a story, I'd do an exam, I'd see some abnormalities, and based on those abnormalities, I'd deduce where his problem was, and that in many cases would tell me what his problem most likely was. And I don't know whether you thought about it or not, but localization is probably the most important thing you do in medicine. If I'm your patient and I come to you and I say, my chest hurts, you've got to precisely localize what I'm talking about. I could be talking about a heart problem. I could be talking about a lung problem. I could be talking about a problem with my ribs or my sternum. I could be talking about an ulcer. There are lots of things that cause pain in the region of the chest. And until you localize it down as to which is the most likely, you can't begin to make a diagnosis. And if you don't have a diagnosis, you can't come up with any treatment. So localization is important, and it's especially important in neurological diseases, because quite often where the problem is, it goes a long way toward telling you what it is. Okay, the first thing we do in the neurological examination is, the mental status exam. This is really important, especially if you're asked to see somebody and there's a question of whether or not they're demented. The mental status exam has 2 parts. the person's level of consciousness and the person's orientation. And suffice it to say, Matt can be fully alert. But the sooner that I realize that Matt doesn't think he's Napoleon waiting on Josephine to show up so we can have dinner, the better off I'm going to be. You can be alert and totally disoriented, okay, and many people with dementias are. So assessing level of consciousness is, by and large, purely observational. See, by the fact that Matt's sitting there, sitting upright, alert, and looking at me, he's alert. Okay, tell everybody your full name.
My name is Matthew Thomas Edwards.
Okay, and where are you, Matthew?
I'm in the Lakeside Building 6.
Okay, what day of the week is it?
It's Tuesday.
And why are you here?
I'm here to learn the mental status exam.
Okay, all right. You're actually here to learn the neurological exam, but that's all right. We'll forgive that disorientation. The thing is, when you check orientation, you check the patient's orientation, Matt's orientation to self, time, place, and circumstance. The medical shorthand that you'll see written, you'll see MSE, abbreviated for mental status exam, and then you'll have some internal resident will write out PT for patient. PT equals A and O times 4. And that means A for alert and O times 4 oriented to self, time, place, and circumstance. And that takes care of that. The cranial nerves. First cranial nerve, olfaction, we don't normally test it unless Matt had a complaint of he can't smell or taste anything. We don't normally test it because we don't ever find anything. It's normal unless you've got a complaint. The first cranial nerve we test is the optic nerve, and there are only a few things we test. There are a lot of things about vision that when you're doing the eye exam you do, but if you show up to do the neurological examination, the two things that you check about the optic nerve are the pupillary light reflex and visual fields, okay? You don't have to turn the lights all the way out in the room, but the light should be lowered. And because if they're not lowered, the pupils are going to be constricted and you're not going to see much of a reaction to light. And what you'll want to do, just look straight ahead, if you will. First thing I do is look at his eyes. You want to inspect, first of all, because 5% of the population has unequal pupils. Nothing wrong, it's just the fact that the autonomic tone is different from eye to eye. And so they may be unequal. They're both, the thing is, do they react briskly? And so what you do is just look straight ahead, take your light, shine it, watch the people come down, come away, let it come back up, and do it again. And then you want to wait a couple of seconds and check the other side, because you'll recall pupillary constriction to light is a consensual response. When I shine the light in Matt's right eye, the left eye constricts as well. Someone has mentioned something about swinging the light from side to side. Don't do that. The swinging light test is a very complicated test that's done by ophthalmologists looking for very specific diseases. And it really doesn't have any place in the normal screening exam. Just what I've showed you is all you need to do, okay? Visual fields is next. And a couple of points about it. Everybody close your left eye and look straight at me. Now, when you've got your left eye closed and looking straight at me, what you're seeing with your right eye, you'll notice, Ryan, that I'm what you're looking at, but the world off to your right, this side, you see a whole lot more than on the other side. You open your eyes now. And that's because the nasal half of the visual field is partially obstructed by the fact your nose is sitting there. And that becomes important when you check visual fields, because the first mistake that gets made is we ask our patient to take his hand and cover his eye like that. And doing this, we've now taken my palm and put it on top of my nose, and now I can't see anything until it gets right there. I've created a visual field defect by putting my hand on top of my nose, so don't ever do that, okay? Likewise, having patients hold cards up. This current corner right here is not a right angle, and patients can see around it. You got to understand that the patient will cheat to give you a right answer on an exam. Patients, for some reason, think that the physical exam you do, and I'm talking about anything, is a test you're given and they're trying their best to pass it. So you want to make it difficult for the patient to consciously or unconsciously fudge in any way. So the easiest way to test his binocular vision is to have him take his own finger and just hold the other eye lightly shut, just like that. You don't want to push down like that because that'll blur the vision for a while in that eye. You just want to hold it like that. And then you're going to stand in front of the patient, and if I'm testing Matt's left eye, I'll have him close his right eye and leave his left eye open, but I will close my left eye and look at his open left eye with my right eye, and I'll compare his visual field with mine. And don't be upset if you're standing in front of the patient and you hold your hand way out and both you and he can see it from the very beginning. Unless you have extremely long arms, the temporal half of your visual field usually stretches further than you can reach. The point is that you both should see it at the same time, and that's the whole thing. When he says he sees it, you should see it, okay? Finally, when you move your fingers in from the periphery, move slowly. Give the patient time to react. If you say, tell me when you see my fingers, and you do like that, the guy says, now, and your finger's already in the middle, that's just a bad test. So move the fingers really slowly. And I like to use 1, 3, 5, 7, 9, and 11 around the clock, and that's the way that I do it, and I think that's a pretty good way to do it. And so that's visual fields. Any questions about fields? Cranial nerves 3, 4, and 6 move the eyes, and you know all about making the H. The only thing I have to add about that is, especially if the patient has a complaint of double vision, there can be an intraocular imbalance so fine that you can't see it. And so especially if the patient says that he's seeing double, but even if he's not, when you take your finger, look at my finger right now. Now, as I move it, I want you to follow it with your eyes. If at any point you see double, say now, okay? And tell me. So his fingers go over, and I keep moving my fingers until I see his eyes stop and go a little further. And then I'm going to go up, and then I'm going to come down. Sometimes, depending on how well you can see the eyes, because the whole idea is to see if they're moving conjugately. But if you've asked the patient to tell you if he sees double, he'll pick up loss of conjugate movement, which causes the double vision, before you will, okay? So it's a good thing to do. And then you have him do the other side, okay? So that's 6. The most important cranial nerve to remember how to test is the 7th nerve. And it becomes critically important because now of what we can do acutely within the first 3 or 4 hours to reverse stroke. Matt comes to me and says that last night he had a lot of headache on the right side of his head. And he woke up this morning and it seemed a little worse. And he remembers looking in the mirror at 8 o'clock and nothing was wrong, but then his face kind of felt funny and he went back at 8:15 and the right side of his face wouldn't move right. So he pinpoints the time something goes wrong. And he's in your office now 10 o'clock in the morning, and you do an exam. And your job is, because Matt has facial weakness, does Matt have a Bell's palsy, a lower motor neuron problem involving his facial nerve caused by a viral infection in his middle ear or in the temporal bone, or has he had a stroke? And you got to make that determination, because you don't have time to send it to anybody. Because if you're going to reverse his problem, it has to be done within the 3 hours. He's got to be given TPA, tissue plasminogen activator, if you think he's had a stroke. And if you think he's had a stroke, you've got to do a CT scan first to be sure he hadn't had a bleed in his head, because you don't give TPA if he has. And that's going to take you maybe a half an hour. And this happened at 8:15 and it's already 10 o'clock. So you've got to know how to discriminate between the two on the basis of an exam. If Matt has a Bell's palsy, the whole side of his face is going to be paralyzed. If he's had a stroke, it's just the lower half. Okay? You got to remember that. That's why we test facial nerve function in upper and lower face. Shut your eyes really, really tight. Squeeze them shut. Okay, open them. So I don't have to touch them or do anything. I'm looking for asymmetry. Because if the right side of Matthew's face is paralyzed, when I ask him to shut his eyes, what he's going to do is that. This side is not going to move. There's going to be marked asymmetry. And then I ask him, show me your teeth. And again, I'm looking for asymmetry. And again, if it was the right side of his face that was paralyzed, Matt would go. Characteristically, when this happens, families think that something's wrong with the good side of the face because the mouth draws up and the eyes move, and so it's something wrong with this side, but it's the other side that's obviously the problem. So a Bell's palsy is the whole side of the face. They don't need a CT scan. They just need a steroid dose pack. If they're not better in a week, then you send them to see an ENT physician, and that's how you handle that problem. So remember how the facial nerve works. The eighth nerve, hearing, easy thing. Close your eyes. Tell me when you hear my fingers rubbing.
Yes.
Tell me when they stop.
Yes.
Tell me when they start again.
Yes.
Tell me when they stop.
Yes.
All right, you can open your eyes. That is a great test, general test for hearing. This tuning fork is not. Don't use this to test, whether your patient can hear or not, because you're testing his hearing at one specific frequency. In this case, 125, 128. And most hearing disorders don't occur that low anyway. So he could be deaf as a post and still hear this. This contains multiple frequencies, from low frequencies in the hundreds of hertz up to thousands. It's a very complex sound, and it's a nice bedside way to check whether hearing is present or not. And in a lot of your older people, they lose the ability to hear this. I can't hear it at all. But yet, I can hear reasonably well otherwise, so it's a pretty delicate, test. Okay, 9 and 10 are the gag reflex. The gag reflex is worthless in a normal person for the same reason that checking olfaction is worthless. You're not going to find anything. It's invaluable to do in a person who's hoarse. Suppose that Matt is 50 years old. He started smoking cigarettes in med school, and despite being a doctor, he's smoked all these years, over a pack a day. And he's concerned, and he comes to see me here on Tuesday, because on Saturday he went to a basketball game and yelled like crazy, but when he woke up Sunday, he wasn't hoarse. But yesterday he woke up and he was hoarse. And he doesn't understand that, and he's concerned. I'm concerned because of his long history of smoking, because lung cancer, once it starts to spread, one of the favorite sites it affects is the recurrent laryngeal nerve, and that manifests itself with hoarseness. So, did Matt just yell too loud Saturday at the game, or have we got a really serious problem going on? Do I need to order a chest x-ray which causes a couple of $100? Not necessarily. I do a gag reflex. The afferent limb of that is 9, the efferent limb is 10. And problems that involve the ninth cranial nerve are vanishingly rare. How rare, I don't know. I've never seen one after 30 years of neurosurgery. There are tumors that can occur, but we're talking about zebras with stripes going the wrong way. It's rare, okay? 10th nerve problems are darn common, and they manifest themselves with hoarseness. So what I do is I test Matt's gag reflex. If it's out on either side, I get really worried that he's got a problem with the vagus nerve, and therefore I get a chest x-ray. On the other hand, if his gag reflex is fine on both sides, that means he just yelled too much. And give him a little time and he'll get better. He's just got a little strain of his vocal cords. If he doesn't get better, then we can evaluate it further, but that's just a nice, handy-dandy way. So testing the gag reflex is fine in people to evaluate hoarseness, but really not so much otherwise. 11, the spinal accessory nerve, you test previous function, and 12, hypoglossal function. The best way to test that is not have people stick their tongues out, because a lot of people, especially with long tongues, like Gene Simmons with Kiss, they protrude their tongues asymmetrically. and you might think there's a problem because the tongue deviates to one side or the other. If you simply put your hands on the cheeks, Matt, take your tongue inside and push against push hard, hard, hard. Now push over here. You can really test the strength of the tongue that way, okay? So that's the cranial nerves. Any questions about that? The motor exam, I'm not going to go through in detail. That's all contained in, the handout that you use to do the exam. The important thing about it is if you want to assess whether, let's say Matt says, I'm weak in my arm. How many different things can make Matt weak? Say it's his right arm and his right arm. Weakness of any muscle could be reported as weakness in my right arm. It could be a deltoid, a biceps, and so on. So the thing is, when you're really trying to hone in on whether or not muscle weakness is present, you want to put the muscle at its disadvantage. An example of that would be Matt's triceps. The triceps is the main extensor at the elbow, okay? That muscle is at its most disadvantaged point right at the beginning when it's trying to extend the arm. It's at its maximal strength when it's in full extension. So hold your arm straight out, don't let me bend it. That's the least sensitive way to test triceps for weakness because it's already fully extended. Bring your arm in, don't push it out. Push it out now. And that, see, it's kind of a Mexican standoff. That's the maximum way to test for weakness. So put the muscle at its disadvantage. For the biceps, it would be starting in rather than having the arm all the way in. Muscles draw their origins toward their insertions, and that's how you used to do it. For the quad, I want, push your leg out, push it out, push it out. See, I can hold his quad that way. If I let him fully extend the leg, then I couldn't break it if I tried. Given the fact that most often men are stronger than women, it becomes especially important to do this so that you maximally or most sensitively test the muscles you're trying to test. The other thing is testing muscle tone. Just let your arm relax. There's no way that I can teach you what normal tone feels like. It's just as I passively or as I actively move his arm and I ask him to relax, there's still the slightest bit of resistance. Once you've done that to a few hundred arms, you'll know what I mean. I would strongly recommend that next year when you have rotations, especially over to the rehab, that you examine spinal injured people or strokes, people who have upper motor neuron weakness with spasticity, and see exactly what I'm talking about when we talk about muscle tone, okay? Final thing with the motor system is reflexes. It was a real mistake when this hammer was designed to look like a tomahawk. Native Americans designed the tomahawk for totally different reasons. The flat end of the tomahawk was usually sharpened and designed for cutting, like cutting your opponent's arms or his legs. The pointed end was sharpened, and that was used for penetrating injury, skull, the chest. With the reflex hammer, this triangular shape is utilized, the pointy end is utilized to tap flat surfaces like the patellar tendon. The flat end is utilized to tap rounded surfaces like the tendon of the brachioradialis or the Achilles tendon at the ankle. So when you're going to tap a flat surface, you want to use the pointy end, a round surface, the flat side. The final disadvantage of having this thing look like a tomahawk is most of you guys starting out hold it like a tomahawk. Just like that. Surgeons call this clubbing. Anytime you take an instrument and hold it like this, it's called clubbing because you've taken your hand and all its dexterity and formed it into a club. The only thing I can do with this is just hit somebody with it. What you want to do is hold the reflex hammer in 2 or 3 fingers. I use 3, and I grab it right here where it starts to widen out. That's the point I grab it. And it's held loosely. The thing that stops this from moving is the handle hitting my palm. And you want to try to learn to always use the same stroke, hit with the same force. When you elicit tendon reflexes, you are stretching the tendon and stretching the muscle spindles in the muscles. The harder you wail on somebody, the more muscle spindles you stretch and the bigger flexion response you're going to get. So if you always hit about the same, hopefully the response will be equal. The other thing is, be sure, test for a reflex 3, 4, 5 times until you get an idea of how, the reflex really is, because with all the practice that I have had, I can't always hit with the same force every single time, although it's pretty close. And I might not hit the tendon in the same place. There are just inherent variations there. And as you'll see in a second, you've got to tap several times before you get an idea of whether the reflex is there or not, and if it is there, how brisk is the reflex. Reflexes take on significance according to the company they keep. If Matt had an extremely weak right arm, if he has no reflexes, that suggests this is a lower motor neuron problem. If he has extremely hyperactive reflexes to go with that weakness, that suggests an upper motor neuron problem. So reflexes become important by means of the company they keep. The other thing is, reflexes in the upper extremities are essentially, as a group, more difficult to obtain than reflexes in the lower extremities. What's really important, we get more worried about side-to-side asymmetry. Matt has brisk 2 to 3 plus reflexes in his normal left arm. In his weak right arm, he has no reflexes at all. That kind of asymmetry. But again, things like weakness or numbness accompanying reflexes abnormalities make those abnormalities a lot more likely to be significant. Start off, you want the arms and the legs to be in similar positions. You don't want to test one arm when it's straight out and one arm when it's bent. So I'll generally have the arms both relaxed, and I don't care whether the hand is like that or whether it's like that. I generally put it about halfway so I don't have to reposition it, because I'm going to hit the radial reflex in a minute. The biceps reflex and the radial reflex are both mediated, while they're mediated by different nerves, they both go through the same reflex arc. The C6 reflex arc governs both. The radial reflex is the hardest reflex to obtain of all the reflexes you test for. If you have a great deal of trouble getting a biceps reflex, you're not going to get a radial reflex. That becomes important to know because it's also the most painful reflex, because you're tapping the tendon of the brachioradialis muscle, but that tendon lies right on the periosteum of the radius itself. And all of the pain, the terrible pain of bone injury, think about breaking a bone and the terrible pain you have, every bit of that is periosteal origin. The bone itself doesn't have any pain fibers. They're all located in the periosteum. So while it's okay, if I can't get a knee reflex to tap that patellar tendon a little harder, I don't want to start wailing on Matt's radius. Or Matt may get upset and start wailing on me, okay? Because that can happen. So just let your arm relax. To test the biceps reflex, you want to roll your thumb around in the antecubital fossa until you feel the tendon of the biceps muscle, and you put the tip of your thumb right on top of it, and you take the pointy end of this, because I'm going to hit my thumbnail, and you hit. And he's got a trace reflex. I almost didn't even think he had one. Reflexes can really be affected by emotional state or drugs. I give Matt a couple of snorts of cocaine, he'll have 3 to 4 plus reflexes. He'll be just, People that are anxious and tense have hyperactive reflexes, okay? People that have consumed alcohol, or God bless them, people that have just toked a joint, their reflexes won't come back till next week, okay? So it can reflect emotional state. The thing that I know is, since that reflex is a trace reflex, trying this radial reflex is almost not worth it. I can tap it, and I get a little thing on the thumb there. But again, that's kind of trace, okay? The triceps reflex, just let your arm relax. You want to raise up the arm and just let it be nice and loose. Let it go nice and loose. And with the arm up here and loose, you take your finger and palpate the olecranon process of the ulna. Slide your finger up until you step just off, and that's the triceps tendon right there, and that's where you want to tap with a pointy end. Mad you're just dead and don't know it. Just let it relax, nice and loose. And that's maybe a 1+. As you do a reflex, you do its partner on the other side, okay? You don't check one arm and then go do the other arm. I'm not going to do the other side just to save us a little time. But that's the way you do it. You do both biceps, both radials, both triceps. In the lower extremity, you take your hand and you feel the patella, and then you walk straight off of it, and there is the patella tendon. You can actually press on the skin and leave yourself a little white spot to hit. And that, believe it or not, is a 1 to 2+ reflex. 2+ being average. And you notice I hit it repeatedly to get an idea. And coming over here. Just let it relax. Same sort of thing over here. Now, and you'll have to stand up to see this. No, not you. Sorry. If you look at math, testing his ankle reflex, you first of all look at the way his feet are. And as a person sits without their feet on the ground, the feet hang loose and the feet are normally plantar flexed. When you hit the Achilles tendon, it causes the foot to plantar flex. If the foot is already plantar flexed, unless you do something about that, nothing's going to happen. If I hit back here, look, nothing, okay? What you have to do, let your foot relax, just let it be nice. You bring the foot up so that it's now at 90 degrees from the lower leg, and now you tap. See the difference? That is a nice ankle reflex. When you get old like me, you can do it without looking at it. It's magic. So you have to raise the foot. I'm not going to make Matt take off his shoe. To do the Babinski sign, you want to take your thumbnail, works fine, a car key works fine, the end of the reflex hammer, if it's not too sharp, works fine, and you come up the side of the foot and across the ball of the foot. When you do that on a normal American adult with a bare foot, what he's going to do is jerk his foot back, because most of us don't go barefoot a lot of the time like we did 150 years ago when Dr. Babinski, formulated this sign. So our feet are far more tender and you just get a withdrawal reflex. But in most cases, the normal response is going to be flexure. If you want to see an extensor replantar response, then go to the newborn nursery next year. Do it on babies. We all have Babinskis until we're about 2 years old. And that's where you'll see it look like. If a Babinski response is present, it just simply says that Matt has some kind of upper motor neuron problem. And I have to tell you that in over 30 years of doing neurosurgery and seeing a lot of upper motor neuron problems, I kind of already knew the patient had a problem because they were usually paralyzed or something like that. And I didn't need that upgoing toe to tell me there was something wrong. So I think it's, you know, Obinsky response is well, it's a response. And I'm not, you know, too sold on it being extremely important. The sensory exam. We test primary and cortical modalities, and the three we test in the screening exam. We test discriminative light touch, pinprick, and joint position sense. That's just by convention. We don't usually test vibratory sense because discriminative light touch and joint position travel the same dorsal column, medial, and discal pathway. We test both joint position and discriminative light touch because even though they both travel by the same neural pathway, there are certain diseases that affect joint position sense far more drastically and earlier than where they will discriminative light touch, and vice versa. And you'll learn this all next year in clinical medicine. For example, when you go over to the diabetes clinic, you'll be using tuning forks on everybody because their peripheral vibratory sense really gets affected by type 2 diabetes mellitus. Okay? Discriminative light touch, the patient, they want to do two things. You want to know the sensations are intact, and you want to know that they're equal on both sides. For discriminative light touch, what I have Matt tell me is exactly where I touch him. Okay? Close your eyes, Matt. When I touch you, say touch.
Touch.
Open your eyes. I have no idea what I just tested. Because there's a sense of crude touch that goes with the spinothalamic tract, the pain and temperature tract, and people have a gross idea that they were touched, but they can't localize where. This, I have to have Matt tell me exactly where I touch him. So close your eyes, man, and when I touch you, tell me the exact part of your body that I touch, like your right thumb, your left cheek, whatever, okay?
My right index finger.
Mm-hmm.
My left thumb.
Mm-hmm.
My left forehead.
Mm-hmm.
My right knee.
Okay, open your eyes. It's intact on both sides. When you do this for your exam, be sure you cover all three phases of the trigeminal nerve and the arms and the legs, okay? The thing I haven't answered is whether or not it's the same on both sides. And Matt might feel it much better on one side than the other. So close your eyes, Matt. When I touch you now, tell me exactly where I touch you.
My right knuckle.
Okay? How about now?
Same left knuckle.
Okay, are this and this the same or different?
They're the same.
Okay, open your eyes. I do several different areas. You want to touch homologous areas. You remember from Dr. Ray's neuroscience lectures that different areas of the body have different receptive fields. Fingers are much more sensitive than the shoulder or back. So you want to compare homologous areas, thumbs to thumbs, foreheads to foreheads, to be sure you feel it the same, okay? Now with joint position sense, the way you do it is how sensitively you do the test. Joint position sense is knowing where your fingers and toes are, and normally in a screening exam we do it with the thumb and the great toe. Obviously, if he came in complaining of a numb right upper extremity, I might well do the joint position sense in every single finger, tailoring the exam to fit the problem. But on the screening exam, what you do, you don't want to give the patient any hints. You don't want to lead him. So you want to grab his thumb just before the interphalangeal joint, just hold it lightly, and then I'm going to take the other hand and grab it just distal to the interphalangeal joint. And I'm going to move. Close your eyes. This is up and this is down. Up, down. You got that?
Yes.
Soon as you know whether it's going up or down, I'm going to start moving it slowly. Soon as you know which way it's going, let me know.
Up.
Soon as you know, let me know.
Up.
See, the movement's almost imperceptible.
Down.
And that's the sensitivity. That's about as sensitive as that can be done. So the way that I would find side-to-side differences is, let's suppose that imperceptible movement is correctly identified on this side, but on Matt's other side, I have to literally raise the thumb all the way up and all the way down before he gets it. And even then he might have trouble. That shows me there's an obvious difference from side to side. Okay? Okay. Final thing is pinprick. You really need to carry a safety pin with you and some alcohol swabs. The alcohol swabs are probably not necessary because if you hold the safety pin by the clasp like this and hit the average person on the skin, you're going to excite those pain fibers, but you're not going to break the skin, okay? When you break a Q-tip in half like you're taught to do, unless that broken tip is sharp enough to stimulate those pain fibers, when you touch the patient with that broken tip, you're stimulating touch fibers. And you and the patient are making a deal with reality that just, having a deal that has nothing to do with reality. So you wipe the tip, close your eyes for me. First, I want to find out if you can distinguish the scents. This is dull, and this is sharp, okay? Dull and sharp. What's this, sharp or dull?
Sharp.
What's this, sharp or dull?
Sharp.
What's this, sharp or dull?
Dull.
How about this?
Sharp.
And this?
Sharp.
He discriminates it everywhere, and I also test his face and his legs, okay? Now, we want to know if there's any difference from side to side. Close your eyes for me. This is sharp, and this is dull. What's this?
Sharp.
And what's this?
Sharp.
This sharp, same as this, or are they different?
They're the same.
How about this sharp and this sharp?
No. Left was dull.
Okay. And you want to trick the patient. Try to trick them, okay? Because if you just always hit them with a sharp end, they're going to guess even if they don't know. So that's the way that we do that. Then we look briefly at what the cortex does with this information. And all this information goes to the parietal lobe, and then it's analyzed. And this discriminative light touch is what I utilize to know without looking that I'm feeling my ballpoint pen, that right there is the clip that fits into my shirt. And if I pull these two apart, the points inside, and that's the top of the pen and the bottom of the pen, that's all discriminative touch. That's what you use to explore things. So we really test what the parietal lobe does with discriminative touch by testing for stereognosis, which is object identification without visual cues. Close your eyes for me. I'm going to put something in your right hand. Feel it and see if you can tell me what it is.
It's a quarter.
Can you feel and tell me which is the head side and which is the tail side?
This is the head side.
Okay. Can you tell me what day it is? Date it is? No. All right. And then I would do it on the other side, okay? Most people can not only identify as a quarter, but with large coins like this, they can identify the head side or the tail side. And no, nobody can identify the date on the coin. What you now want to do is find out if the parietal lobes talk to each other, because they do that by going through the corpus callosum, and there are a lot of nasty diseases that destroy the corpus callosum. So close your eyes for me, Matt. I'm going to put something in this hand, in this hand. What can you tell me about what you have?
They're both coins. This one's smaller.
The one in your right hand is smaller
The one on my right hand is smaller.
than the one on the left. And that's, you can open your eyes now. You'll be having, and that in fact is exactly right. If Matt didn't have a corpus callosum, he might well be able to tell me, what he had in his right hand, because he speaks out of his left hemisphere. And even though he might be aware there's something in his left hand, since that's over in the right hemisphere and has to get across to the corpus callosum, when I asked him what he had in his left hand, he would have great difficulty telling me what it was. And he couldn't begin to compare the two, okay? So that's why we do that part of it. The other thing, graphesthesia, asking him to writing numbers in his hand and asking him to identify, basically tests the same thing. Anything that's going to knock out stereognosis is going to knock out graphesthesia, so it's probably not that essential to do. Final thing is coordination. A lot of this you already know. Remember, the cerebellum vermis controls the trunk, and if you remember from last year, alcohol is a specific cerebellar toxin. If Matt had a problem with his cerebellar vermis, he would have been sitting there slurring his speech like somebody who's intoxicated. He would have also been weaving back and forth. But the most sensitive test of function of the cerebellar vermis is heel to toe walking. Can you stand up for me and walk over here and turn around and face me? Just walk over there normally. All right, turn back around and face me. All right, now put one foot right in front of the other and walk a straight line. Excellent. About up here. There are some normal people who, just for genetic reasons, have difficulty with tandem walk. Just like there are some people that have difficulty riding bicycles. You know, there's not any human trait we have that there's not some exception to, but the vast majority of people can do that quite normally. Or when they start, they'll tell you, I've never been able to do this, and so you have to discount it. But the person with a vermal problem, when he has an unstable base, first of all, as he stands there, the first thing he's going to do to steady himself is widen his base to keep from falling over, okay? So he's going to be kind of like that. And as you ask him to narrow that base to 0 by putting one foot in front of the other, first of all, as this foot comes forward, there's no guarantee it's going to land where he wants it to. And so he'll fall forward, and then he's wavering back and forth. He's like a guy on a high wire. He's constantly moving, and he'll fall to one side then the other. He's an equal opportunity staggerer, you know. And this becomes important because when you deal with dysfunction in the cerebellar hemisphere, if my right cerebellar hemisphere is all fouled up and I'm incoordinated on my right side, when I try to tandem walk, my left foot goes exactly where I want it to. But when I try with this right foot, it may wind up over here and I'll stagger off. So people with hemisphere disease, if they try to tandem walk, they will stagger off persistently to the bad side, okay? Which takes us to the last thing, finger to nose and heel to shin, which are the two best ways to test hemisphere function. Right cerebellum controls the right side of the body. So take your finger, touch your nose, touch my finger. Okay, go back and forth. And you want him to fully extend his arm to do this. And now once he's doing that, keep on, we want to make it hard for him. Because I'm moving in a circle and he has to make constant mid-source corrections. And I can't look at Matt while he's doing this, otherwise I will just reflexively take my finger to meet his. And that's the way that you test finger to nose, okay? And you do that on both sides. You can test rapid alternating movements, but anything that fouls up that is going to foul up finger to nose. And if you've got problems in your right cerebellar hemisphere, when Matt tries to take this finger out, you get this, what we call the intention tremor of cerebellar disease. This smooth back and forth is lost. And the movement, there's decomposition of movement, and the movement breaks down, there's pass pointing, all those things, and you just get this kind of thing. Heel to shin, test function in the lower extremity. It's uncommon to see cerebellar disease just affect the arm, not the leg. Most of the time it affects both. What you want to do, take your right heel and run it straight up and down your leg. Good, you can put it down. It is absolutely best, and the way you never do this is have him sit there and just raise it straight up and down like I'm doing right now. Because this part is Matt, this part is gravity. And gravity always follows in a straight line. So you want the person to lie down and do this when they're supine, okay? Okay, any questions about what we went over? Thanks so much, Matt. You can have a seat. Appreciate your help.